One of the nice things, one of the wonderful things about being a part of the University of Michigan, as Dr. Hu said, is we have all sorts of expertise right here at the University of Michigan. And so I'm very pleased to introduce our keynote speaker, who is one of the United States' top geriatricians. He wears many hats, Dr. Ray Young, who is the director of the Geriatric Center and the Institute of Gerontology. Title of his talk is, Where Will the Puck Be? The Future of Geriatric Medicine. And by the way, for all of our speakers, the bios are in the program, so we're not going to spend a lot of time talking about people's backgrounds. You can look at it there.
Thank you. So while we are, actually you may have to lock on again. Okay. So I want to thank you for the introduction and for inviting me here today. And as was mentioned, I wear a number of hats, and just a quick word about the Institute of Gerontology. It was founded back in 1965, and that was the first state-sponsored institute focused on research of many aspects of older adults, that recognizing that there was a time when Medicare was first introduced to the country, and that the aging society will need a lot more information if we are to improve the care of these older adults. And I believe I'm the 8th director of the institute now since that time. And the Geriatric Center was established, the Interdisciplinary Geriatric Center was established back in 1987, and by Dr. Jeffrey Halter, whom some of you know. And Jeff retired recently, and so I became the director of the center as well. And I'm also an MD. I do clinical work, and so this talk will bring in the medical aspect, a little bit of medical aspects of how I look at aging from the geriatric medicine perspective. And the title of the talk is Where Would the Puck Be? The Future of Geriatric Medicine. And many of you probably recognize that I paraphrase the quote from the great geriatrician and gerontologist, Wayne Gretzky. It says, I skate to where the puck is going to be, not where it has been. So as we think about the future, we want to think about not where things are just today, but also where things are going to be as we move forward. And as a clinician, when I give a talk, I usually like to put things into a more human perspective. It kind of reminds us why we're here. When we discuss about transportation and other needs, we actually really talk about people. So I wonder how many of you remember seeing this story. It was broken in CNN and many other news outlets a couple of weeks ago about this couple, Wolf and Anita Goschuk. And for those of you who only maybe watch Fox News, let me just quickly recap for you what the story is about. So Wolf is 83 years old, and his wife Anita is 81 years old. And the story is about how for the past 8 months, they have been living apart in 2 different nursing homes. And the problem is this, that Wolf has dementia, he has congestive heart failure, he also has lymphoma, and so he requires a lot of care. His wife, Anita, is in better health, but still needs to be in a nursing home. And because of different level of care, they ended up to be apart from each other. So you see, Wolf married Anita when he was 21, when Anita was 19. And this is the first time they have to be apart from each other, frankly, in the adult life. And what happened is their granddaughter then basically every few days will drive them so that they can be together. And this picture is when they say goodbye to each other. So at the end of that meeting, when they have to say goodbye, they hold their hands, then they cry, and then they have to leave each other. So when we think about what we're going to do, what you will be doing, and the research that you do, the idea is that we want to think about what we can do to impact the lives of people like Wolf and like Anita. So that the idea is that we can help so that fewer people, and that's my life goal, is that fewer people will end up living alone or living in a place where they have to be institutionalized. The idea is that we want to keep them so that they can age in place. And so that's kind of our goal. So as we go through this conference, I hope you keep that in mind, that human face to what we are trying to achieve here. So I think we all know about the silver tsunami. So the silver tsunami is here and will be here for the next few decades. And this picture basically showed the percentage of older adults. I don't like to use the word elderly because, soon it turns out a lot of my colleagues have reached the age of 65 and so on, and just calling them elderly just doesn't, calling them elderly and other terms just don't seem to be right. And this graph, the top graph, basically show the percentage of older adults, meaning those that are over age 65, by country. So you can see that back in 2000, year 2000, the only places where you see where there are populations or countries where the percentage of older adults is in the range of the 15 to 23% or 22.5% would be in Europe and in certain parts of Asia, like Japan. But as we look forward in the next few decades, and hopefully I will be one of those people, is that in 2050, if you look at the world, it will look very different. And so these colors, particularly if you look at the checkered color, including the United States and Canada, we are now talking about 30% or more of the population will be 65 and above. So that's what we are facing in this world. And I was in Japan a few months ago to give a talk in a conference, and I was shocked to find out that in 2016, there are already places and areas in Japan where there are more than 30% of the populations there are over 65. So for them, the future is now, is not even in a few decades. This is already happening. So we are facing this, whether we like it or not, the silver tsunami is here. Because we're in Michigan, I thought we'd just look at Michigan as an example. Michigan, in terms of looking at the geographic area, is a little under about 100,000 square miles. And so we are pretty average sized state. We are the 23rd largest state of the 50 states, so we are in the middle of size. In terms of population, we have just under 10 million people here. And so we're the 9th largest state by population. And we're also the 10th oldest state of the union. And the interesting thing when you look at our state and the demographic changes is that we are seeing, for example, a lot more minority elders in the urban areas. So this is something that when we plan about thinking about future, the care of people, we have to think about the issue, the socio-economic issues that includes things like race and gender and so on and so forth. And by 2040, 23% of the population in Michigan is projected to be 65 years old and above. And this is some graph that I made. So when we look at the state of Michigan, and it reflects what is really true around the country as well. So the green color here represents what are considered rural counties in Michigan. Those are certain definitions. So you see that the majority of the state, of the 83 states of counties in Michigan, some 57 or so are considered rural counties. And so that's rural counties are also where there are increasing percentage of older adults. So when we think about transportation issues and so on, obviously we have to think about where these people are going to be. And the middle graph here, MUAP, stands for medically underserved area and population. So all the red areas are considered medically underserved area, meaning that there aren't enough doctors to serve, the primary care doctors to serve the needs. And you can see the vast majority of the state is in that red area. And then I put down here, on the third graph here, the location where counties where there's at least one geriatrician. And you see that just like expected, all the doctors are primarily residing in areas where there's an urban area rather than where the needs of the older adults might be. Oops. So age as a healthcare utilization driver. I know I have to put the word driver somewhere in my slides, so we'll put it here, age as a healthcare utilization driver. So not surprisingly, older folks are more likely to utilize healthcare. So when you look at here, individuals by age group, number of people who don't have a regular healthcare provider is much higher than when we're younger, than when we're older. So we need more care, we need more doctor to provide care. And in this particular graph, so even though we talk about over 65 currently represent maybe 15% of our population, you look at the inpatient procedures used by age group, then the 65 and above constitute 37.5%, and then 47% of utilization of diagnostic tests and treatments are in this age group. So clearly, this is where a lot of the cost occurs in this age group. And this is a graph from data from the Kaiser Family Foundation. And they look at the 2011 Medicare data and then ask the questions, which age group utilized the most care? And for physician and outpatient services, so that in these two points in here, the peak age is about the age of Wolf, the person I just mentioned, 83 years old. That's the peak age of utilization of physician and outpatient services. And if you look at other services, like inpatient services, is even older, 89 years old. So I don't want to belabor a lot of these points because I think you're going to get another talk from Dr. Hill later on in this conference to really talk about healthcare utilization. The point is still just to point out the fact that this is where the most healthcare costs is in this age group of patients here. And at the University of Michigan, I just want to kind of talk a little bit about this because many people, when you ask them what is a geriatrician or what's a gerontologist, they will look at you blankly because they really don't know what it means. And so when we talk about older folks, I think it's important for us to remember that it's not a homogeneous group. So biologically and physiologically, when we are young, I look at all the students on campus, they are very similar. But as we get older, we become a lot more diverse. We are a heterogeneous group as we get older. So it's not actually fair to just group everyone over 65 and look at them as though they're a single group. So we oftentimes talk about the young old. So those are the people who may just have been retired. They're still playing golf and enjoying life and so on. And these are the young old between the age of 65 to 74. And we call it the middle old, the regular old, if you like, those that are between the age of 75 and 84. And then we talk about the old. So those are the people who are utilize most healthcare, particularly over 85 years old as well. And then we talk about the centenarian. We have talked about the exceptionally old. We talk about the super centenarian now that we talk about people who are over 110 years old. And so when you think about healthcare delivery, on average, the age of family medicine doctors here, the patients that they look after on average, the mean age is about 40. And for typical internists at the University of Michigan, the mean age of their patients is about 60. And for my group, and I have about 40 faculty in my group, the mean age of our patients in our clinic is about 80 years old. So that's something that when we think about looking ahead in the future, we need training for other people beyond to look after older folks in terms of the medical world. And I want to just emphasize that not every older adult needs a geriatrician. Just because you're 65 or 70 or 75 doesn't mean that you need to have a geriatrician. If you don't have a lot of comorbidities, again, it's a very broad spectrum of people, you won't necessarily benefit so much from a geriatrician either. So thinking about the geriatric medicine workforce in 2016, there are roughly about 7,000 geriatricians in this country right now, and we know that we need about 17,000 geriatricians in 2016, and by 2030, the projection is that we need 30,000 geriatricians. Not going to happen. This is not going to happen. We won't have that many people. And just conservatively, we talk about if you need one geriatrician per 10,000 older adults. And this is the graph showing where there are places in the country, this dark color, black color dots, where counties that you actually have achieved that. The vast majority of the country really does not even have one geriatrician in every 10,000 older adults. I think it's important to also think about the other side of the equation, because doctors are getting older too. Your doctors are getting older. I'm getting older. The physician workforce is getting older, and even more so than the rest of the population. So when we talk about maybe right now 18 or 19% of the population is 60 years and above, but if you look at the physician workforce, 28% of that population are old, 60 years and older, and many are looking forward to retirement. There are going to be a lot of issues, not just about workforce, but about competencies when our physicians are in their 70s, and how are we going to work with them? And the type of traditional, standardized work schedule may not be the right type of schedule, especially since we still need them to look after our patients because there just aren't enough of us around. So this is what I teach our trainees when they come to become a fellow in our program. And when I talk to them, what are you going to be learning as a geriatrician? So I said, geriatric medicine is like a three-legged stool. And the first leg is that you need to learn about geriatric syndromes. And so you go through the whole list of things that they are going to be expert in, that your colleagues and your patients will expect you to be expert in. And that includes what I call the big 3Ds of geriatric medicine: dementias, deliriums, and depression. So those are some of the things that you need to be expert in. And so what I want to do is just very quickly talk about one aspect in terms of Alzheimer's disease that I think you all understand and know, and probably a lot of you have family members or know people or friends who have been touched by this disease. And this is one of the things that we are very excited about in different reasons, for different reasons. One is that we're excited because it's going to be a major problem for us, for the society. The cost of Alzheimer's disease is staggering. We know that as we get older, we are much more likely to develop Alzheimer's disease. So the incidence of Alzheimer's is going up and up and up. The prevalence of Alzheimer's is just continuing. As we live longer and longer, we'll have more and more people. So you look at the right-hand side of this graph, if you look at the cost of death, so with all the medical advances, now HIV is really a chronic disease. It's no longer a life sentence the way that I remember when I first started my medical career as a medical student and as a resident. It's no longer, so the death rate has been decreasing over time. Similarly, things like stroke that cause death, we know that over 90% of the causes or contributors of strokes are potentially modifiable. And with all the advances, there is fewer people now dying from stroke. Same thing for heart disease, same thing for other conditions. A lot of the cancers now, we do so much better in terms of allowing people to live much longer. But we don't have good treatment for Alzheimer's disease at all. And so the cost, Alzheimer's cost of death continues to increase in percentage over time. The good news is that this year, the federal government has increased investment into research in Alzheimer's disease. And so this year, the National Institute on Aging received a $350 million boost in research in Alzheimer's disease. And this next year, similar amount is going to come through as well. So we're really excited. And so one thing I just want to mention to you so that we don't get our hope up too much it looks more and more like the focus is going to be on early disease and even preclinical disease, because it looks like it's really difficult to cure or change the trajectory of disease when it's so too late in the course. So what you will see in the future, and is currently now, is that the focus in research is looking at much earlier. People who just started having some memory issues. People who may have a family history, you have the wrong genes that may predispose you. That may be the group that we most like to impact for future care. The second leg of these three-legged stool I mentioned to our trainees is that is the intersection with medical specialties. So I listed some of them and say, what do you mean, blood pressure goal? Don't you teach them in medical school what the blood pressure goal should be? Yes, we do, but what do they rely on, the data they rely on, where does it come from? Well, clinical study, of course, you say, and it's true. But who are the people in these clinical studies? So you may have a large study, look at blood pressure goal for a population, and then you say, well, with this blood pressure, you improve your life expectancy, you improve your mortality, you reduce cardiovascular outcome by so many percentage if you achieve that goal. But then the question is, who are the people in the studies? Are they the people who are going to be in the population that we're seeing now and in the future? And so, well, yes, this study has about 10% of participants who are 70 years old and above. So surely that's okay. Well, let me tell you this. This is what I call these people in this study. I call them elderly-like creatures. So yes, they are 70 years old by age, but they're nothing like the people I see in my clinic. If you, for example, this is a study that just came out too, that's the SPRINT study that hit the New England Journal of Medicine. And then this is a follow-up study on those who are 75 and above. And actually, we are one of the sites that participated, key site participate in recruiting people 75 and above in these studies. And then in those prominent journals that most of our patients may read, Wall Street journals, whatever journals, what is the message to them? That you need to get your blood pressure, the systolic blood pressure, down to 120. It's going to have a 25% reduction in all-cause mortality, a 30% reduction in cardiovascular events. But what is kind of lost, for example, in these studies is that, oh, by the way, they exclude people with diabetes. So when you think about it, for example, a third of people in this age group has diabetes. So you can go on and on and on. So part of what we teach our fellows and trainees is that you have to understand these nuances. And I think over in the next few decades, what we're going to see more and more is that people are demanding that you have to have the right people in your study that reflect the populations of people that you're going to be treating, because we're going to be relying on this data to help make clinical decisions. And the third leg of the stool is what I call the system of care for older adults. And so typically, now trainees need to be expert in Medicare. Healthcare insurance changes so rapidly. We need to know. It's no good. I prescribe a drug to a patient and say, take this, it's really going to help you, but it's going to cost him or her $25,000 a year. They can look at me and say, doc, that's all very well. I'm not taking this. So healthcare issues has policies and costs. All these things are going to be key issues. And so it's important for our trainees, and as time goes on, we have more and more new system of care. And the goals of this system of care are always this, to how can we improve the outcome and reducing the cost of care. And that has to go hand in hand. You can't just have one and not the other. So we are in the big three countries, and so I thought, well, that's the big, but they're also the big three of geriatric medicine, what I call the big three of the future of geriatric medicine. And those are the three things that I think you're going to see: hyper efficiency, personalized medicine that Dr. Hughes had mentioned, and technology-assisted medicine. And those three things are here, and they will continue to be dominating our field in the future. And unlike the big three where they may compete with each other, in this situation, they are all interdependent. So these three things, I just want to briefly talk a little bit about it. Think about hyper-efficiency, and we need to increase the efficiency in this high-cost healthcare environment. So we hear a lot about how the United States healthcare utilization is higher than any other country in the world, and that's true. If you look at this graph here from OECD, United States by far, in terms of the percentage of GDP, utilized the highest percent, had a high percentage compared to any other country. And then Japan is down here, and here. It used to be down here, and it's now gone up quite a bit. And you look at all these different countries. But I want to look at also a little bit more in this. So if you split it up now in two graphs, public expenditure versus private expenditure. So that means what percentage of that is provided by the government versus the consumer, the public, has to pay out of pocket themselves. If you look at that, you might see a little bit different picture. So you look at the United States, about just under 8% in the 2015 statistics. And you look at the other developed countries here, actually we're not that far from all these other countries, surprisingly. But what is big is that we see the private expenditure part is substantially higher. So this is where when you see your physical therapist, they say, thank you very much, this visit is going to cost you in addition $30. Or if you go to the health store and they say, I'm going to buy this to help me sleep or help me make stronger, whatever that might be. And this may be, you go and get a cane so that you can walk better, whatever. So if you look at that, a lot of this is in the private expenditure column. And that has a lot of implication as we think about how to make healthcare more efficient and what it means in terms of the split between private expenditure and public expenditure. So we always talk about there's ways that we can improve, and it's estimated that there is a lot of waste in medical care. So there's a column here, the largest column here is a 37% here, unnecessary care. So I just recently heard a story. It's a veterinary story, so it actually makes it a little bit easy, so it doesn't make it too personal. So one of my colleagues have a dog, and so one time this little puppy decided to just swallow one of her socks. And so she took it to the vet to say, I'm worried about it, she looks okay. And said, no, this is important, we need to get it out. And so, they kept her there for about 6 hours, and they gave her some medicine to help her throw up, and got it. And then, so when she walked out, they say, oh, by the way, here's the bill. It's $850. And said, well, wait, what happened? What make that cost? Well, we put an IV in just to make sure there's some fluids, and that IV bag is like $75. And by the way, we also gave her a shot of B12 because after she throw up and so on, she's going to feel tired, and we want to make sure that she's really active and piped up and so on. Really, I mean, puppy, 3-month-old puppy, I think a little bit quieter for a few hours is not that bad. Oh, that's $125, and so on and so forth. So you add up the cost, and so she paid the cost, she paid the amount, and then a few weeks later, it's all on her. Same thing happened again. The puppy swallowed another sock. So he said, boy, you know what? I'm not taking it to the vet this time. So look on the internet, and what do you find? Well, you find so you just give some hydrogen peroxide, whatever mix, and you can induce the vomiting. And so $1.25 later, she did that, and the puppy threw up the sock, and all is fine. And then the cost of less than $2 was $850. So you can think about more care is not always better care. So part of that is in that box. And fraud and abuse, there's nothing that riled up a lot of us more than fraud and abuse. And I have been expert witness for the federal government in some Medicare fraud cases, and some of the things really just makes you really upset about why and how can people do things like that. So there are a lot of things that you can think about where there will be some cost saving through this type of initiatives. And, but how is it going to achieve that in other ways? Well, surprise, surprise, money drives things. So there are many carrots and sticks now in place for health system to incentivize and to drive behaviors. And more you're going to see medicine this way. And there are more and more we do now non-traditional office hours as well. So evenings and weekends. It's just a surprise that people still get sick weekends. I don't know why, but they do apparently still get sick weekends. And so if you actually have office hours on the weekends, they don't end up having to go to urgent care and emergencies to have something relatively simple that you can take care of. So more and more now at the University of Michigan too, we have non-traditional hours in most of our services now. Outsourcing functions. So I wonder how many of you yourself or your family now when you go to a doctor's office don't see a doctor anymore. You go to the doctor's office to see a nurse practitioner or a physician assistant. My family do. I mean, they may see the doctor once a year, but the rest of the time they see a nurse practitioner. So utilizing physician extenders is now the standard in order to drive down costs and improve efficiency as well. Technology-driven care is something that is coming and is here and will continue to be more a part of our lives. And there are various consolidation, new alliances going on in Southeast Michigan, for example. And there may be news coming out very shortly about this. And we also getting more and more specialized in the location, the type of care. So we have different IST, hospitalists, SNFists, and all these new names that are now there as we move on to this brave new world of healthcare. Publicly available cost data will be there to help consumer better choose where to go to and what type of things you will choose, where you should go to get your care. And the cost reduction has to be balanced by quality and performance. So all these initiatives are always linked to various quality improvement, and these are just some of them that we all face today. And the payment system that's beyond the point of care. So now, more and more, it goes back to the 80s and 90s, of those of you who still remember when we talk about managed care. So it's another different form of managed care that is now coming up, but with a greater focus on quality this time. And there are different ways to reduce care, the use of SNF and so on. And there are also other consequences. I mentioned that it means likelihood is that there will be much greater out-of-pocket costs for our patients. And many procedures that used to be done inside a hospital will be done in the outpatient setting. And patients who get discharged, those people who have, say, hips and knees replacement, they used to mostly go to get some rehab therapy before they go home. Now they all get sent home. Very few people now actually end up in the rehab center. You will just get your care now at home rather than in all these high-cost facilities. And so there will be a reduction in the cost of inpatient care, but then likelihood there will be increase in cost of out-of-hospital care, but at a lower cost location. And again, shifting costs. Now more and more that the private part of the equation of healthcare is going to increase. Personalized medicine, genetic-based and cell-based therapy, very exciting time for us, particularly at the University of Michigan, where we are at the forefront of a lot of this therapy, but it also high-cost therapy. The reality is that all this personalized medicine also may mean higher costs as well. So we have to balance that in terms of a lot of things as we move through this brave new world. Privacy issues, because now based on those data, it's not just the diagnosis of diabetes that a third of people in this age group will have. They can pretty much, you can potentially identify someone just because of all the precise data about you is out there without your name, and essentially is your genetic signature that's out there as well. Home-based technology, so we talk about transportation here, and a lot of my patients can't come to see me because they have transportation issues, and a lot of them don't have, just like at Wolf and Anita, rely in this case on their granddaughter to help move them around, and a lot of the young people do work. So this is a conference that can help think about some of the options and how to deal with the rural America as well, where they have the highest percentage of the elderly. And now technology is there. I don't have to see, I can see my patients on the screen, and I can get their, I can listen to their heart, I can listen to the lungs without, even if I'm 1,000 miles from them. I can look at the ears, look at their eyes, I can do all sorts of things. The technology is there. The problem right now is that technology is way ahead of the payment model. So we are not doing a lot of this because the payment model is not yet there to allow us to do. But technology is there, it will catch up with time, in time. Just before I finish, I'm just going to talk very briefly about some brave new world that you might not be thinking about. Is the world of translational research. We tend to think about clinical, preclinical in a very separate way. But more and more we really are thinking about things, how do we bridge that gap? So this is actually an article published in Science a number of years ago now, and basically you see is here. Well, we know that, say if you are 50-year-old today, a 50-year-old woman, you can expect overall, on average, you will live to about 80, early 80 to your early 80s. That's what we can expect to happen. But if we cure all the cancers, no more cancer, cancer is going to be wiped out from our vocabulary. How many years of life are we going to extend as a whole population for this 50-year-old woman overall? It's only a few years. Same thing with heart disease here. And if you cure both cancers and heart disease, no more cancer, no more heart disease. How many years of life are we going to add to the population? And here we can see that, well, from the 31 year here to now here, a little bit under 40 years. And if you look at cure cancer, heart disease, stroke, diabetes, you can extend that from here, 31 year to maybe 46, 47 years of life. But we know from all the preclinical trials and studies that we can extend lifespan potentially 30, 40, 50% in some model system. So that's the potential that we can extend lifespan much more. And when you extend lifespan in these model organisms, what happens to them? Well, they have fewer diseases. It's not just lifespan, but health span also seems to improve as well. So there's a lot of interest, and we avoid using the dirty word anti-aging. We don't want to use that word because it's a bad connotation. We try to avoid that. But it is true that more and more there's this bridge going on now to try to bridge the basic science, how we can translate to improving health and lifespan of humans. And the first study, some of you may have read in articles like in Science and other magazines, Taming Aging with Metformin. And so this is the first clinical trial in humans in the US to look at how a medication may potentially help increase lifespan and improve the outcome of multiple diseases. So I started off the talk talking about Wolf and Anita, but I want to again end the talk with a little bit brighter note. It's not all the same as we get older, and so this is just a collage of pictures, and on the top left-hand corner, this is Flying Phil from South Africa. He ran 100 meters in 26 or 27 seconds. He was a centenarian when he did that running, when he ran that 100 meters. And the last thing I wanted to say is that it's to impart on you one more wisdom, and this is the Ray Young's definition of successful aging, which is really encaptured, if you like, in the lower right-hand corner here. And the definition of successful aging from this geriatrician is have daughters and granddaughters if possible. So I have 2 girls, and for those of you who only have boys, good luck finding a good daughter-in-law. That's all I can say. So thank you for your time. Appreciate your time here.